So I'm Tim Price. I'm a medical oncologist at the Queen Elizabeth Hospital, but I also lead the clinical research program there, and I'm also part of the Basil Hetzel Institute Solid Cancer Program. My main focus though is on gut research, which includes colorectal cancer, gastric cancer, pancreas, etc. We look at a broad spectrum of clinical trials, from phase 1 studies for patients who have exhausted standard therapy. They often look for new treatments, so we're looking at novel protocols, novel drugs, and particular targeted drugs for that patient population. But we also have studies that look at first-line therapy, so patients who are first diagnosed with colorectal cancer, for example, again with usually novel therapies, but nowadays what we're able to do is select treatments for individual patients, so very much a personalised approach. So that's both in the clinic but also with our clinical trials, and what that allows us is to have very targeted molecules that are likely to improve patients' outcomes. Now that may be survival, may also be their quality of life, which is also very important. And because of these very targeted agents, we're also likely to reduce the toxicity because they're specific for that patient group, and therefore better tolerance, and for patients in particular, that better outcome in terms of less side effects is really quite important. One of the benefits of the clinical trials is that it does identify molecular subgroups. So a lot of clinical trials now will do screening, and they'll be seeking a particular molecular profile of a patient group. But what it also then does is identify other what we call mutations. So we may be able to either seek out an alternate trial, we may be able to seek out access to a drug that we know targets that particular profile. And the reason we do that, of course, is that there is already some evidence that patients' outcomes, again, survival, quality of life, delay in tumour growth, cancer growth, will be impacted by those particular targeted therapies. So for example, the immunotherapy trials that we undertook some year or so back, that was a particular population of colorectal cancer. The survival, or what we call progression-free survival, so control of the disease, was on average around 8 or 9 months. With this particular target therapy, that became around 16 to 18 months. And in fact, what we found was that nearly 50% of patients at 2 years had disease control. Previously, that's not what we see for advanced colorectal cancer. So that was a dramatic impact of that particular treatment. The other important aspect of that example is that that particular drug, what's called immunotherapy for that patient population, is incredibly well tolerated. So if we think about chemotherapy that can cause diarrhea, mouth ulcers, fatigue, nausea, etc., in some patients, not all, but immunotherapy generally is very well tolerated. There are some rare side effects that can occur, but otherwise patients will generally just continue on normally and really have none of those chemotherapy side effects. So that's quite a dramatic difference. So improved disease control, which means survival also, but dramatically improved in terms of the side effects of the treatment.